the risk of diabetes goes up. And this is body mass index of 35, and that places you at your risk of diabetes about 90 times higher than if your body mass index is down at this low level here. Okay, so that is the key. That is the key driver. But age is important. Whether you're male or female is important. Your family history is very important. Your ethnicity is very important. But despite all of those things, diabetes does not develop in the absence of weight gain. Okay, so you could have all of those factors, but if you maintain your weight at the right level, you can prevent it. Okay, but that's very difficult in this society. So if people, anyone who has diabetes or is at risk of diabetes, the doctor or nurse or whoever will tell you need to lose weight. But they don't understand, they don't explain why. I'm talking about weight and I'm talking about it generally. But what is it about weight that causes diabetes? So I'm going to try and explain what is actually going on inside the body when we start gaining weight and we are susceptible to getting diabetes in the first place. Because as I say, some people can be very, very overweight and they'll never get diabetes. Okay, probably 3/4 of the population who become very overweight will not get diabetes. So you have to have the susceptibility as well as the weight gain. When I talk about calories, do people understand calories? Calories in food, yeah. So if we have too many calories over time, okay, and gradually our weight goes up, what happens is we start to put fat in the wrong places. So first of all, it goes into the liver. Okay, so we start by we're eating more than our body requires, easily done, and we gain weight. We can pinch it, we can feel it, we can see it. That fat is not a problem. Okay, it's a problem because our clothes feel tighter, or we want to look differently maybe, but it's not a problem for your organs and your diabetes. Okay, it's a problem when you exceed those stores, and what happens then is you start putting the fat into the organs. So it goes into the liver first of all. The liver doesn't just keep the fat in there. Over time, it distributes it to the rest of the body. The liver, a fantastic organ. It keeps us alive because when we don't eat through the night, it pumps out glucose, sugar, to keep us alive, feeds our brain. But the liver and the fat in the liver gets distributed to the rest of the body, okay? And that includes an organ called the pancreas. The pancreas is the master regulator in diabetes because it produces this hormone called insulin. And insulin has lots of jobs, but one of the jobs is it gets sugar out of the blood and into our body's tissues where we use it for energy, okay? So what is happening is we have too much fat in the liver, and you become, too much fat in the liver means that you become less sensitive to the effects of insulin, okay? And also, with too much fat being pumped out by the liver, it lands in the pancreas and it blunts the production of insulin. So you have two problems. Call it the vicious cycles, if you like, two vicious cycles. Too much liver fat means you're not sensitive to the effects of insulin. Too much fat in the pancreas means you're not producing as much insulin as you need. So these cycles kick on, and essentially, we give people medications to try to be more sensitive to insulin or to produce more insulin, but they don't tackle the underlying problem, which is the fat in the organs. And that is reversible if we address the calorie intake, and we can help people to lose weight. Because when you lose weight, you then start to use up the fat within the liver, and you become more sensitive to insulin, and you get the fat out of the pancreas, and you start to produce more insulin again. So it is possible to do this, but the timing is important. if you have too much fat in your pancreas for too many years, you can lose the weight, you can get the fat out, but the cells in there that produce the insulin, they won't wake up and come back to normal. So timing is important. It needs to be done, as soon as possible after diagnosis, if that makes sense. Okay, I'm going to move on from that one. So that's the kind of the cause, is weight gain, but it's weight gain in the wrong places. Talking about weight gain, so rates of obesity in the UK and actually across the whole world, okay, have been going up for decades, for about 40 years. And this is not the fault of individuals. This is the world around us has changed. We have easy access to food. So individuals in terms of human nature have not changed particularly, probably, but the world around us has changed, and we've seen a steady rise in weight. And in the UK, in the 80s, about 5% of the population had obesity, okay? So, a weight above a certain threshold that we believe to be unhealthy. It's now about 30%. More like 30%. So from 5% to 30% in a whole population. And in America, it's worse. But the whole world really has followed that trend, and no country has reversed that. So this is not an individual problem, it's a societal problem. And so this is not about blame or shame or any of that. It's about trying to understand, what the challenges are and what we can do about them. So talk about the environment and also genetics. So some people are much more prone to weight gain than others. It's as simple as that. It's to do with about 50% of weight problems of obesity, overweight and obesity, is explained by genetics in the brain. The genetics in the brain control appetite. How full we feel, how hungry we feel, these things. So it's very, very much driven by genetics, about 50%, as I say. And it's the same applies to thinness. So some people you will know, they seem to be able to eat whatever they like, they don't gain weight, they're very, very slim. Okay, despite the environment that we live in, that I'm talking about, is very obesity promoting. But these people don't gain weight. They are actually about 2/3 of the population are overweight or have obesity. So people of a healthy weight are in the minority, but they do exist, and it is also influenced by genetics. This is a slightly complicated image, but basically you have along here we have people who are resistant to obesity and people who are prone to obesity. Now, if they live in an environment where, if people who are prone to obesity live in the 1940s, they're not going to become obese because the world around them doesn't promote that. If you put them into 2025, it's much, much, much more likely. But the people who are resistant to gaining weight, even in today's society, they're less likely. They'll gain a little bit of weight. They will gain a little bit of weight, but they are unlikely to develop a real serious weight problem. So we talk about the interaction between our genes and the world around us and the environment. And these foods people will recognize. That is quite common now, isn't it? So on average, we eat about 500 calories a day more than we did in the 1970s. So as a natural consequence of that, we gain weight. But at the bottom here, it's saying the social environment promotes obesity. So it's it's a normal response of individuals, of normal people, to a world that is, a bit abnormal, I guess, in a food context. Now, we like these foods. They're tasty, they're enjoyable, and food serves many, many purposes beyond health. And so it's part of the challenge of losing weight. Eating healthily is even more difficult for the poorest members of society. So people living in poorer conditions is much more difficult because healthy foods are more thank you, are more expensive. So healthy food is twice as expensive as unhealthy food on average. So this is called the Broken Plate. It was a report published this year, and that was part of their research. And the people in the 20% most deprived areas of the UK would need to spend around half of their disposable income on food in order to eat healthily. It's not workable. So this is part of the wider things that are promoting obesity within the population. Okay, so understanding your risk. Okay, understanding your risk of diabetes. So there are simple ways to do this. First and foremost, I'm going to talk about the South Asian context. So on average, type 2 diabetes is diagnosed 9 to 10 years earlier in people of South Asian or Black ethnicity compared to white. Okay, and that's based on data from 1 million people in the UK. So you develop the condition, let's say, a decade sooner. Okay. And the other thing is that, and I guess part of that is that you have less way to go to develop diabetes. So in terms of weight gain, okay, this is a slide showing people of white ethnicity in the purple, South Asian in red, and Black in green, okay? And this is weight gain required to develop type 2 diabetes compared to people who don't have diabetes, okay? And this is age along here. So at an age between 20 and 40, okay, people of South Asian ethnicity need to gain about 12 kilos compared to people who don't have diabetes, okay, to get to diabetes. But people of white ethnicity, double. So I would need to gain, on average, about 24 kilos above a healthy weight for me to develop diabetes. Whereas you guys would need to gain half of that to develop diabetes. So that demonstrates the susceptibility, it being much higher in the South Asian community than it is in white. And you know, the susceptibility is highest in South Asian populations, but Black not far behind. Okay?
George, can I ask
yeah.
Does people understand the susceptibility of South Asian people is double than the white population? And there is no, George, you told me there's no obvious reason for that? Is that how?
So genetics. Right. Genetics is a key part of that. Typically, on average, muscle mass is lower in the South Asian population, and muscle takes glucose out of the blood, and is a site for it being used essentially. So that is. And so average height in populations, in Asian populations, is smaller, which is a sort of a proxy measure for muscle mass also. So one good way of from a prevention point of view, actually, in an exercise sense and weight-bearing exercises is useful from that point of view. But yeah, I think genetics, reduced muscle mass, is not probably fully understood, I guess. There seems to be a tendency for South Asian to store fat in the wrong places, you know, more likely to do that than white populations, and at lower weights. So if you don't need to gain as much weight, and you live in this world where it's easy to overeat, then it's clear that you know, risks are higher.
Please come in if you have any question. Even if you want to ask in Urdu, I'm here to translate to him. Please come in, involve in discussion, ask your question, clarify. George is very happy to have discussions rather than, you know. So just if you have a question, you're not clear, please come in and ask the question so that we have a good discussion on. You understand what it is.
After question in terms of measure of the weight, we didn't mean anything because different people will have different heights and age factors as well. So how is linked with BMI? What is the bottom line in terms of BMI?
What is the, sorry, in terms of BMI?
So what should be the BMI for someone to be susceptible for getting the diabetes?
Yeah. So this is the point I was trying to make there about BMI is okay for looking at populations, but in an individual, if an individual comes to see me and they've got diabetes and their BMI is 24, then their BMI probably needs to be 21 to not have diabetes. If their BMI is 40, then maybe they only need to be down to 35. Now, people would still say that that is very overweight, but the diabetes goes away at that point. So I'm going to talk about how much weight you need to lose if you get diabetes. That might help. But does that answer your question? BMI is not the best and most sensitive way so we could say, well, your risk of developing diabetes is quite low if your BMI is below 25. But it's not nothing. There's still risk there. But your risk goes up, you know, with BMI. We know that with increasing BMI, lots of things, lots of health conditions are more likely. And if you maintain a healthy BMI, then your risks are lower, but they're not nothing. And in the South Asian populations, the risks are higher, even at lower weight. And maybe the bad news for the audience is that the risks are highest in men. So on average. So again, similar slide, it's now looking at men in blue and women in red. So to develop diabetes, women need to gain more weight. And especially you can see this is between age of 20 and 40. So it's about 24 kilos. On average, people with diabetes are higher in weight than people without diabetes. And you can see that the gap in the graph start to narrow as age increases. Anybody have a thought on why men may be higher in weight, higher risk of diabetes than women? Because we store our weight there generally, and that's where the liver and the pancreas is. So the fat, where we store our weight, gets into the wrong places, if you like. And women are protected against that to some extent until menopause, and then the weight gain tends to be more on the tummies, and then the risk increases at that point.
George, in our community, the women are less mobile because of obvious reasons, cultural reasons. Do you not think this is a risk factor for women because they are less physically active? That exposes them and increases their risk? No?
Lack of physical activity is a risk factor for diabetes, but men are at significantly greater risk of developing diabetes. We're probably, as a society, not that active. We aren't. 17% of the population get the recommended level of physical activity. Again, it's just the jobs that we do, the life that we all have cars now. We sit at desks. We don't have to be active. You have to go out of your way to be physically active. Back in the day, it was totally different, obviously. So the population as a whole are not active. Women are maybe more so, in this community, but it doesn't. I don't think it has it may not be having a massive effect because it's the weight that's the key. Physical activity is important, but it's not. If you're very physically active but very overweight, your risks are still going to be there, although they'll be less if you're very overweight and inactive, if that makes sense. So men are slightly higher risk. If you want to find out your risks, there's very simple tools that can be accessed online. We have one on our website, Type 2 Tayside. You can check it out, or you can go on the Diabetes UK website. And there's very simple risk calculators. You put your own details in there, and it will estimate your risk of developing diabetes. So they're quite handy tools. But we talk about the ethnic group, our family history, increasing age, being male, being overweight. These are the key ones. These are the key risk factors. Diabetes is kind of difficult to pick up because the symptoms of it in the early stages are kind of like, you know, you could put that down to something else, you know, feeling a bit more tired, maybe getting up to pee in the night, maybe more frequently, these types of things, you know, but you could put that down to something else, you know, so the symptoms are not always obvious. So you can calculate your risk online, and if you score a high score, you should go to you should contact your GP practice and ask them to test your glucose. Okay. What about prevention? Is diabetes preventable? Yeah. Can you, once you have it, can you reverse it? What's that?
What if you reduce your weight?
If you reduce your weight in time, yeah. Yeah.
It can be reversed. Depends on your diet. You change your diet.
It is reversible.
Go into more your greens, and I've seen people do that.
Yeah.
They go into your more green diets, like say your vegetables and boiled stuff, and it's something you have to adapt to.
Yeah.
Change your diet.
Absolutely. So it's been known for 25 years diabetes was preventable. So there were studies done involving thousands of people in Scandinavia and also in America. And what it basically showed was that if you lose about 6 kilos or so, you have a very good chance, if you have pre-diabetes, of stopping the progression onto type 2 diabetes. So what was basically shown was over a 5-year period, people who went on this lifestyle program, they had pre-diabetes, they went on a lifestyle program, they lost about 6 kilos. And they compared those to people who didn't go on the lifestyle program. And the people in the lifestyle program, there was a 60% reduction in progression to type 2 diabetes in that group. And even when they looked at them again at 10 years down the line, there was a 34% reduction in progression to diabetes. So that weight loss, even if it wasn't fully maintained, because it wasn't fully maintained, has a legacy effect. So so modest weight loss, 6 kilos is about a stone. Do you guys tend to work in kilos or? Yeah, kilos, so about 6 kilos, 5-6 kilos maintained, that can significantly reduce risk of future progression of diabetes, or you delay it, you delay the onset of it. As I say, if you get diabetes in your 70s, it's not a big problem, So that's prevention. Prevention, very possible, and it's been well known for quite some time that can be achieved. What's been less well known is about what we call remission of diabetes. So you get diabetes, but you put it into remission. Remission's a sort of phrase that we talk about with cancer usually. What we're saying really is reversing diabetes. Can you reverse it? I was part of a study which was published 7 years ago now, and it was the diabetes remission trial, and it was run at Glasgow University. And it's really that put remission of diabetes on the map. Until then, people didn't really, as a concept, type 2 diabetes wasn't thought of as being reversible. Okay, but we did a study in Scotland of 300 people, and we put them on a low-calorie diet. And you can see it here. Soups and shakes, 800 calories a day. That's what it was. That's what we put people on. And these were normal people with diabetes, diagnosed in the last 6 years, from all parts of Scotland and some in Newcastle. And they were seen by their nurse or their dietitian. So it was not a big fancy research study of really well-motivated people necessarily. They were motivated, but they were just normal average people with diabetes. And nearly half of them got their diabetes into remission at 1 year with an average weight loss of 10 kilos, okay? And they achieved this using the shakes and the soups. So they replaced their norm for 12 weeks with shakes and soups, okay? It sounds tough. It is not easy to do, but most people found that actually to be easier than keeping the weight off afterwards when they reintroduced food. So it was just healthy eating. This is the Eat Well plate, the food pyramid, the just standard healthy eating advice after the soups and shakes period. And it worked really well. I worked on the study, and people found the break from food. They didn't need to think about food. They didn't need to cook or plan or prepare or anything. It was done. They didn't feel too hungry. They managed it. Look, people weren't necessarily perfect. There was the range of weight losses. The average was 10 kilos, but some people lost 20 kilos. Some people dropped out and didn't lose anything. But around 80% of people were still going, were still in the program at 1 year. So the results was good. It was in a real world setting. So the Scottish Government took that on board, and they've given funding to all the health boards to roll this program out, and that's what I'm doing. Okay, so I'll talk to you about kind of how we're doing in Tayside with that.
Can I question?
Yeah. Yeah.
In diabetic for about 25, 26 years.
Yeah.
There's a chance for my diabetes to be reversed.
So the chances of remission at that stage are very low, in all honesty. Okay, it's not impossible. But there have been studies that have looked at when people have had diabetes less than 4 years versus 4 to 8 years. And the chances of remission are about 50% less in people between 4 and 8 years. Now, Roy Taylor, I don't know if anyone's heard of Roy Taylor, but he was one of the authors of this study. Okay, he was one of the professors on the study. And he understands the mechanistic stuff that he's done lots of scans of people's livers and pancreas and stuff like that. And he, I know, has had letters from people who have had diabetes longer than 20 years and got their diabetes into remission. The key things is about looking at markers of progression. The more medications you're on, the less likely you are to get remission. If you're on one medication for diabetes, you have a good chance. If you have 2 or 3 or more, the chances are much less. So that is a marker for the progression of it. If you need more medication to control it, it suggests that the ability of your pancreas to produce insulin is much, much less. So, so remission is much less likely as time goes on, but it's not impossible. And it's not all or nothing either. So remission is, not having diabetes means your blood sugars are not at the diabetic level and you don't need any medication. But there's areas for improvement. You could have really poorly controlled diabetes and be on several medications. And with weight loss, you could improve your blood glucose control, improve your health, reduce your medications. It maybe not remission, but improved management is a very good outcome as well. Okay, because people can get into remission, but they may not stay there. So they may come back in a few years if they regain the weight. But that doesn't mean that it was a waste of time. They've knocked the diabetes back. We follow people up at 5 years, in fact, and they had many less medical events in that 5-year period, even if they had lost the remission, if that makes sense.
Okay, if we finish the program around 3:15. People okay? 10 minutes. We take your time because we're running a little bit late, and we'll be finishing hopefully by 3:15. And George will be able to finish by 5 minutes, 10 minutes past, and then just 5 minutes for the final things.
The thing about that study that I just talked about was there was very few South Asian people in it. So the one that we wanted to find out, how does this apply? Because it may not work as well in other communities, in other cultures. So we did another study, and we did a study just in South Asian people. And what we found was that people lost less weight on average, but they still were able to get remission. So they start at a lower weight. The average weight of people within the study was 88 kilos. And 1 in 3 people got remission. 1 in 3 got reversed their diabetes. And this was using the same program, shakes and soups. Okay. And I again worked on that study as well. And it was a very enjoyable study to work on. And people were very grateful to take part. And the way in which the reversal of diabetes happens is exactly the same, whether you're white or whether you're Asian. It's about reducing the liver fat. And when you reduce the liver fat, everything can come back into normal. And we looked at other things. We looked at quality of life and these sorts of things. And these also improved significantly. So this approach works. It works across cultures. And it's a successful approach. It's not the only way to do it. The weight loss is the key. Whether you do it with shakes and soups or whether you do it with your own approach, it doesn't matter. The weight loss is the key, but this seems to be an approach that probably on average works better than just asking people to reduce their calorie intake, eat differently, blah, blah, blah. This is a kind of a structured, intensive approach for a couple of months that people can kind of get into and buy into it and achieve real significant improvement in their health. This is a scan of a liver. So the green in the liver here is fat, and this is before weight loss. And after weight loss, you can see the fat in the liver disappears. And as I say, that's the key to reversing type 2 diabetes. So that was taken from one of our studies of an individual. It's just a slice of an MRI. But it's sometimes useful just to visualize, actually. Okay, so you maybe don't see what's going on inside the body, but these are the changes that happen with weight loss. Okay, so services available through NHS Tayside. So we've talked about actually this is preventable and it's also reversible. And so we are offering these approaches to people across NHS Tayside. Now we have specific criteria for these because the funding that we get from Scottish Government is, as everyone knows, we don't have an unlimited funding for health service. So it's restricted to specific groups. So our diabetes prevention program, we use a provider called Second Nature, and it's a digitally led program. So it's delivered through a smartphone, but it's based on the same evidence of the prevention programs I showed earlier on. So it's 6 months of one-to-one support with a nutritionist, and it's done by a messaging platform.
6 months ago, right? I wasn't checking my sugar levels. I'll be honest with you. The past 10 years, never checked my blood sugar levels. Didn't bother. I thought I was taking medication. I was, injecting, but a very small dose, right? So 6 months ago, I was asked to give a blood test. I went to the doctor, gave a blood test, and the results come back and sugar levels are very, very high. These come and get in touch. I went back and they sent me to Mangalore Hospital, diabetic clinic. From there, I wasn't given enough support, to be honest with you. I was told basic things, you need to do this and this. I took it upon myself, as a person. It was me who was feeling bad. So I asked for a sugar monitor and asked for the thing that's necessary. So from there onwards, I started to take control. I'm checking the blood sugar every day, twice a day. Medication, I've adjusted my medication to my needs. I was injecting 46 units per day. Since the fasting, mine's come down to 30, because I lost about 5 kilos in weight.
Very good.
And my personal health has become better. 6 months ago, I couldn't sleep. I used to lie awake in bed all night, wake up the next day, go to work, But now, since I've taken control of it, I'm much better. I can sleep for 4 or 5 hours now. Yeah. My health seems to be that better. So.
Very good. It's excellent.
This should be promoted.
Yeah.
People should be made aware of these things. Doctors don't spend enough time. No. They don't give enough time for the patient to make them understand what you have to do.
It's a personal responsibility you take, and then you get that success.
I've been diabetic for 25 years. That between the start of my medication to the point that 6 months ago, nobody really got. For 10 years, nobody ever even invited me to come and have a blood test or see how my diabetes getting on,
We wanted to, George was interested, we wanted to develop a group that can be supported, George.
Yeah.
There's need for this.
And salvation.
I think the problem you make is an important point. Okay, the problem is that health services are just swamped with and it's that doesn't mean that people don't need support, because they do, but the growth of diabetes in Tayside, there's 25,000 people with diabetes, and they might get one appointment per year to check how they're doing. It's not enough to
7 years, and then not even one of them.
that there's something not right about that. You should be checked on annually, but it's not enough. If you want to make changes in your health, you need sort of, well, a lot of people can do it, and you're doing it now, and you're doing it yourself, and that's brilliant. Some people need support and follow up, and so, but it's difficult when the numbers are so high and the funding is not there for health services. We're talking about lifestyle support, for prevention programs and for remission programs, but that's not the same as the support that's required for people to manage their diabetes, in the longer they have it, So this is also really important. So we have a diabetes prevention program for people with pre-diabetes and people who have had a history of gestational diabetes as well. Okay, so it's available for people who have had diabetes during pregnancy, or they have pre-diabetes. Pre-diabetes is when your blood sugars we call it HbA1c, which is your glucose levels over 2 or 3 months, and it has to be between 42 and 47. But that's who the prevention program is available to, and for people aged up to 70. So I'm gonna signpost to our website, Type 2 Tayside. If you Google Type 2 Tayside, you'll find the website. You'll find the prevention program. We've had 250 people start this. The average waiting time to start on it is about 10 days, so you can get going really quickly. It's digitally delivered. And the average weight loss is 6 to 7 kilos. The level of weight loss required to prevent diabetes is as I spoke about earlier on, and that is a QR code that would take you to the prevention program on our website, and information about it. So if you want to find out more, then you can find it there. Our remission program is exactly the same as the one I described earlier, with the shakes and soups and the longer term follow-up. We deliver it in a group setting, and Imran was saying there, we could potentially come down and have a diabetes remission program in the mosque or somewhere within the community. We want to understand kind of the needs better, and we have some signs that I noticed have been up about asking people to complete a survey, so that we can understand what is it that people need, because at the moment our diabetes remission program in Tayside, we've had a couple hundred people do it. We've only had, I think, 2 or 3 Asian people take part. So we need to try to improve the uptake in the Asian community, where the risks of diabetes are higher. So we're doing very well. We're doing similar to what we achieved in the research. Over half of people get their diabetes into remission on this program. It's for people who have diabetes diagnosed in the last 3 years and aged up to 65. And the average weight loss is about 15 kilos. So this is the rollout of the research within the health board locally, and this is the eligibility criteria that we work with is what we are advised upon by Scottish Government, and that is a QR code for anyone who wants to find out more about the diabetes remission program. What about do it yourself? Just do it yourself. That's DIY weight loss. You don't need actually necessarily, and you're speaking to that, you don't necessarily need to follow a program or go to the health service. people can do it for themselves. Some people can be very successful. There's no one best way to do it. We're using the shakes and soups, the total diet replacement approach. On average, that's probably the best. But when you look at the food-based approaches to weight management, there is no one best way to do it. Myself and a colleague, we wrote a research paper on this. We evaluated all the different ways you can lose weight: low carbohydrate diets, fasting diets, low fat diets, commercial programs like Slimming Groups, Weight Watchers. We looked at all of them. On average, they all work. They all work reasonably well. But no one way works for everybody. And they probably even themselves out. It's about finding something that you can sign up to. It's finding something that suits your preferences. And probably the other outside factors are more important. So I kind of drafted up 10 top tips there. The first one is you have to want to do it. It's about making the decision and committing to it. That's obviously, that's quite obvious, but it's important. It won't happen on its own, and it's difficult to do. Focusing on small changes, keeping it simple. It doesn't need to be too elaborate. Starting small, focusing on one thing at a time. We're talking about the food environment around us that promotes overeating. It's about trying to control your own food environment at home so that the most tempting things are not there, because although the motivation might be strong at the beginning, a bad day at work or a stressful thing or tiredness or boredom or just temptation, if it's there, it's gonna go wrong. So fix your own home food environment to reduce the temptation. Keep into regular meal pattern so you don't get too hungry. Breakfast, lunch, and tea. Be careful with the snacks in between. Be careful with the evenings. Getting enough sleep, really important. If you don't get enough sleep, how do you feel in the morning? You don't feel good. You want to eat more. You want to get comfort. And they've done studies on this, and people who get less than 7 hours of sleep a night more likely to gain weight than people who get between 7 and 9 hours. And there's also hormonal aspects to that. Hunger hormones that tell our brain we feel hungry are higher when you're sleep deprived. So there's a science to it as well. So getting enough sleep, being active, these are all things we know. It's the implementation of it. It's this tricky part. Planning, meal planning, taking time to think, what am I doing for the week? Monitoring what you do. Getting on the scales, weighing yourself once a week, keeping food records. It makes you think more about what you're eating. All of these things, simple to do, simple to say, more difficult to do, but they do work. Beware liquid calories. The full sugar drinks. They're a bad idea. Be consistent. Don't aim for perfection. We can never be perfect, but be consistent across weekdays, weekends. Be flexible though. Be forgiving, because we're going to all slip at times. So it's a challenge, but it can be done. And in terms of reducing calorie intake and managing portions, I put up some pictures here of maybe more commonly eaten Asian foods. So it's achieving balance. So for example, curry and rice, is an absolutely fine thing to have, but it's about portion size. So down here we have the calories and the fat and the effect on the blood sugar with this kind of portion. If we bring in vegetables, if we bring in salads and create more balance, we massively reduce the calories and the effect on blood sugar. So it's things like it's sort of trying to make, I guess, more simple changes. Don't need to actually change the food that you eat, but but the quantities are important. These again, other things. Oh goodness me! Imran said about gulab jamun, amounts. Again, calorific, but life's not fun if you don't have these things. But it's quantities. So 3 has a big effect on blood sugar and calorie intake. 1 or 2 obviously is a better way to go. And the same applies for all foods. These are samosas, these are parathas. You know, added fats, you know, is a big thing. So trying to reduce the energy density, the calories per gram of food is important, and fat is the most calorific. So 9 calories per gram of fat versus 4 calories per gram of carbohydrate. So moderating amounts can make a big difference. You don't need to change what you eat, but the amounts. And if you keep the volume high by adding in things like salads and vegetables and things, you keep the portion size kind of larger, but the calorie intake comes down. I'm not going to make much mention of this. I'm just finishing up now, and it's about weight loss medications. People may have heard of these things in the news. Ozempic, semaglutide, tirzepatide, Mounjaro, these types of things. They're highly effective for weight loss, and they deliver significant weight loss that's sustained over time. But you need to keep taking that medication. It's like blood pressure or blood glucose. If you stop taking the medication, the blood pressure goes up. If you stop taking these medications that help to suppress appetite, the weight goes back up. But they are highly effective, but they should be done with support. We don't have it on the NHS yet. So guys, to summarize, and thanks very much for your patience and thanks for listening. Type 2 diabetes is driven by excess fat within the liver and the pancreas in susceptible people. The South Asian people are at high risk, at younger age, and lower weight. Diabetes, type 2 diabetes is preventable and reversible, but timing's important, okay? With remission, timing is important. We have effective services available. We want to encourage more people from the Asian community to take them up. We want to understand the needs of the community better. And so to do that, we will ask you to complete a survey and also to share it throughout the community so we can understand where do people get their health information from. Why might they not do this? How can we engage better? You know, where can we promote information so that people hear about it? That type of thing. So you don't need to have diabetes to complete the survey. Your views and your insight into how things work would be really useful for myself and for colleagues. Thank you. Yep. Information about people who have, for people who have had gestational diabetes. Yep.
Menopause and diabetes, if you are diabetic or pre-diabetic, does that mean when you go through menopause, are there other implications around health? I think that would be quite useful.
Menopause would be a wider thing, not my specialist area, okay? But in terms of, you know, there can be aspects of menopause that make weight management more difficult, yeah? So for example, we have our diabetes prevention program for people who have had gestational diabetes, and there would be information probably within that regarding menopause. But for people who have had gestational diabetes, they have a 50% chance of going on and developing type 2. And risks are high in the first 5 years after. So again, timing important there. So, and checking in with your GP practice to get your follow-up blood glucose done every year, that type of thing is to keep an eye on it. But weight loss, again, is the key to prevention. And that's why we don't wait for people to get pre-diabetes if they've had gestational diabetes, because it already tells us they're very high risk for diabetes in future. So does that answer?
Yeah, and I'll pop into the survey, but it would be good if maybe some of those information would be available in the slides. I think that was maybe for the female community, just kind of give them a bit of insight, because they might not always link those two things together.
Yeah. So, I mean, in the slide, there's links to the prevention program. And if you go to the prevention page, there's information in there. It does mention about people with gestational diabetes being eligible, that type of thing. So, but even through the website, you can make an email if you want to do that and put it for my attention. Then do that. Or I think I can give you my email address if you want to contact me. Okay.
George, email available in the poster we have advertised.
Yeah.
And also this
Yeah, give me-
program is recorded, audio is available. So you can go back and listen to this program once again. Many of those things that George today has discussed, clearly in this time we couldn't really cover, but clearly it's an ongoing process. We're not going to leave it one session. So we have a plan to do session after session. Every 2 months, there will be either mental health, diabetes, other topic areas. So you can bring up your questions even next time. George's email, my email available. We have a generic email available. So if you have a question, individual nature of question, ask that question through the email, you will get the answer. But we will continue this dialogue and discussion. So I think before we get to the food is waiting there. Are there any questions from you to ask George? And now for the benefit of others, yes, please.
How can you increase muscle mass?
Muscle mass, any exercise, most relevant to that would be resistance exercise using weights. So yeah, that would be, and it's not just, it's I guess, it's not just doing it once, obviously, it's trying to, a couple of times a week, using weights for exercise would be of benefit. But any exercise, if you were to do nothing just now, even starting with walking would help to develop muscle strength and legs and things like that. So any exercise is better than none. You know, start and build up. But using weights, even body weights, press ups, these types of things. Doesn't need to be a full-blown press up. It could be press ups on the knees. You know, so body weight exercises where you're using muscles would be the way to do it.
Yes, please.
So you mentioned about the program that it's only like this site is providing support to the patients. But is there any other companies as well, or is it only this site?
Yeah, all health boards in Scotland offer programs for diabetes remission and diabetes prevention. What they are doing, I can't exactly say. I would say in Tayside, we are ahead of most health boards. But yeah, you know, but remission programs should be available in all boards. It's the capacity, the service capacities are going to be different in different health boards.
So if you have a specific health board area, just let us know. We can try to link you up with them or send you the link. You can get there if it's a Grampian or 5 or
Yeah.
Sorry?
Yeah, Aberdeen.
That's Grampian. I worked previously there, so it's not a problem. We can link you up with them as well. Okay, just contact me.
Thanks very much, everybody, for your attention.
Can you give us some advice on something like you can do in Ramadan?
What you can do in Ramadan or not? Yeah. I could send you some advice. I could send you some information. I mean, I think as a general idea, fasting, you know, lends itself very well here to weight management. I guess it's what happens once you break the fast. So it's all of the general health eating principles, I guess, which maybe don't lend itself so well in a time of celebration. But it's yeah.
If there is an idea of we can have a specific program before next Ramadan around fasting.
Yeah. There is information that I could share.
Yes, please.
Yeah, and
There is information about fasting and diabetes. Information with me, and I will share with the group, and you will get to listen from you the different challenges. So that's why we will continue this dialogue. That means before next Ramadan, we could have a one session on diabetes and fasting. So that's where you can prepare yourself for the Ramadan. Before Ramadan, we will prepare that session and then come and deliver that session. So that could be possible as well. Okay, is there any other question before you finish off? So my request to you before we get to the food, on this table, right and left, these tables, there are also these barcodes. Can I request, please pick up your paper there or scan the barcode and try to do the survey. The survey will help us to design further programs and intervention and help George to try to understand what is the need, right? So please try to do that. Survey if they're not understanding, or please forward this survey to your friends and family. Try to tell them, request them, please complete that survey. Very important survey for us to get the information and then plan something for the next time. The next session we are planning will be mental health, and that will be in June at some point. We will share the dates with you, and hopefully here or maybe in another mosque, we will have a similar type of session, 1 hour, but that will be focused on mental health, one of the topics in mental health. But thank you for joining me to clarify, George, and for his time and contribution. Thank you. Thank you, George.
Thank you very much.
Thanks a lot.
There are things I didn't know about, but I'm not more aware of.
Thanks.
That's really from what was, and I really look about information and knowledge. So thank you for that.
Thanks a lot.
Very, very, very useful.
Thanks very much. Appreciate that.
Thank you, brother.
George.
Cheers. Cheers.
Thank you so much, George.
Thanks a lot. Thank you. Thanks for coming.
Wow.